And so Derek has stepped in as our seminar speaker for the day. And I think all of you know Derek well, but for formality, and also, just in case you didn't know this, I want to highlight that our Dr. Dosdall graduated from Brigham Young in 1999, right? And born in Michigan? New York,
actually born in Utah, but grew up in Michigan.
Sorry, you have told me, but grew up in Michigan, right?
Grew up in Michigan.
Yeah. And it returned, you returned before college or you returned for college?
Returned for college.
And then it did his master's and PhD at Arizona State, then went down to Alabama for his postdoctoral training, and then has been at the U since 2010. And he's currently tenured associate professor in the Department of Surgery, Division of Cardiothoracic Surgery, investigator at the CVRTI, longtime investigator, and fortunate for all of us, myself certainly included, associate director of the CVRTI. Derek's research has been primarily on using large animals to study arrhythmogenesis, and it now has included heart failure as well. And Derek, as a sign of a strong and true investigator, has remained focused on these topics, whilst the field, some of us, like the mouse and the molecular guys, have moved over to him. So, and in fact, it's not just us, it's the NIH. Right now there's an NIH study section on large animal models. So I think what characterizes his research is not just his focus and his expertise, but also his collaborative nature. We're frankly, one of the aspects of science is it has perverse rewards for selfishness. Who's the senior author? Who's the first author? This is, my lab's work. And, with that comes funding and Nora, of course. But when we can overcome those sort of inherent incentives for the larger picture and work together, then we really can do some actually amazing things together. And Derek has long-standing collaboration with a number of investigators here at of course, at the CVRTI, which we'll hear about today, and which is growing into a personal collaboration with heart failure and heart failure therapy. And it's that nature that actually has made him an incredible associate director of the CVRTI, because CVRTI has really developed very well over the last few years in terms of finding science-produced investigators, number of investigators. And Derek has worked tirelessly for that effort. And to highlight what is a truism that comes late to us, late to most of us, is that, when there are titles are more than, words of distinction that are put at the end of a letter. What the truth of the matter is that what goes along with titles is an enormous amount of hard work behind the scenes that nobody says thank you for. And what results is productivity, the development of the CVRTI, which Derek is part and parcel with it. The development of a seminar series, which Derek is entirely responsible for. And so really, at some point, not during the seminar, you can raise your hand and do this, but maybe better afterwards. Just do what I don't do often enough and say thank you to him for all that he's done for all of us. And so with that, looking forward to hearing about role of ventricular conduction system and arrhythmias and arrhythmia therapy. Dr. Dosdall, take it away.
Thank you, Robin. That was a very kind introduction. Next time, if I want a better introduction, I might just have to invite my mom to come introduce me, say nice things about me.
Yeah.
Thank you. All right, so as Robin mentioned, I've been working a lot in the last couple of years on heart failure and things, but done a lot of work in antiarrhythmic therapy and arrhythmogenesis. And I gave a talk the other day in cardiothoracic surgery, and Craig Salzman was kind of on me because I was talking all about this CBIN-1 therapy and how great it was and everything. And so I promised him on Tuesday, I said, all right, I'm going to give a talk on Thursday, and I'm not going to talk about CBIN-1 at all. And he said, okay, you know, just want to make sure I still have some other things going too. Anyway, thank you. To start out, I want to get my slides to advance. There we go. Okay. I do need to disclose at the beginning that Robbie and I do have a patent on some anti-tachycardia pacing of the conduction system at the University of Utah, so I have to disclose that before I talk. And Medtronic has donated some of the leads and devices that we're using in some of the studies here. Otherwise, just to start with a basic review of the ventricular conduction system. Stuff that you're all familiar with. The activation begins with the sinoatrial node, spreads through the atria to the atrioventricular node, and then from there, there's a conduction delay and goes into the His bundle. And then we have the left and right bundle branches that feed into the Purkinje fibers. And the Purkinje fibers, oh, it's not.
It's going on. Let me see.
And we're having issues with the.
Sorry about it. Let me see. Leave this.
I'm gonna give on a minute here.
Just like this.
Well, Alan's getting this figured out. I'll just mention that, as Robin said, collaboration and working with other people, especially people a lot smarter than me, has really been important in my career. So hopefully that'll come through, that most of this work is only possible through collaboration. Okay. So the conduction system, here's a Guyton Hall textbook of medical physiology view of the activation times that accompany this activation through the ventricular conduction system. You have activation that starts in the SA node and then proceeds to the AV node, where there's a substantial delay, 130 millisecond delay in activation before it gets to the His bundle. And this allows for contraction of the atria, filling of the ventricles, effective contraction and synchronized contraction of the ventricles. So there's lots of reasons why the conduction system is important in sinus rhythm. Now, it's been largely ignored in arrhythmias such as ventricular fibrillation, which is the most deadly arrhythmia that exists. Ventricular fibrillation typically has been described as in one of two ways. Wandering wavelet reentry, so a number of competing wave fronts that collide, self-annihilate, regenerate, and the heart has been described as a bag of worms, you know, just kind of quivering, doesn't contract synchronously and move the blood through the body. Another mechanism that drives ventricular fibrillation is mother rotor reentry. So a large stable rotor that rotates around, typically some anatomical construct, and then daughter wavelets spin off from this main rotor, but it's kind of driven by a central rotor. And so there's this big debate back and forth: is it wandering wavelet reentry or mother rotor reentry that drives ventricular fibrillation? And what we know is that ventricular fibrillation evolves over time. Right at the very beginning, when the heart is well perfused and everything, we have different things that happen. So this is a patient that had a Holter monitor on when they went into ventricular fibrillation, and you can see this rapid, sharp deflections that occur in the first part of ventricular fibrillation, but over time it slows and becomes more coarse. And so this has been divided into type 1 and type 2 ventricular fibrillation from the body surface EKGs. Way back in the 1930s and 40s, Carl Wiggers did high-resolution, high-speed cinematography of fibrillating hearts and divided it into 4 different sections, 4 different time points over the first few minutes of ventricular fibrillation. And other groups have divided it into different things. It's not all the same. It evolves over time. Why is that important? Well, one of the observations in the lab that I was in at the University of Alabama, Birmingham, the Raymond Eidecker lab, we were looking at mechanisms of ventricular fibrillation. What do we do about it? And how does that affect treatment? We did a number of studies where we put plunge needles, so needles, electrodes with active recording sites along the shank of the needle. So this has 6 electrodes, with 1 being closest to the endocardial surface of the heart. So this would be an open chest preparation. Put the electrodes through the wall of the heart, and electrode 6 being close to the epicardium of the heart. And what we found is that in early ventricular fibrillation, the endocardial and epicardial activation rate were very similar during the first couple minutes. But then during the first 10 minutes, there was a slowing of activation rate on the epicardial surface, but not on the endocardial surface. So the endocardium continued to activate rapidly, the epicardium kind of slowed down, and this was in a canine model. When we repeated this study in a pig model, we saw a slowing of activation rate over time, but the rate gradient didn't develop. The endocardium didn't activate more rapidly than the epicardium. And we wondered, okay, what's going on here? Other groups had published similar results where the endocardium continues to activate rapidly and the epicardium slows down. And a number of explanations were brought up and dismissed as not relevant. The blood pool is high in oxygen, and so the endocardium continues to activate rapidly. But that didn't happen in pigs. It didn't go the same way. One difference between pigs and dogs is the distribution of the Purkinje system. And in humans, dogs, primates, rabbits, and rodents, the Purkinje system is limited primarily to the subendocardium. So within a millimeter or 2 of the endocardial surface. Whereas in pigs, goats, sheep, some other species, the Purkinje system arborizes like a tree through the myocardial wall, and there are connections between the Purkinje system on the endocardium and the myocardium throughout the bulk of the left ventricular wall. And so we decided, well, to really know what's going on in arrhythmias like ventricular fibrillation, we really need to record from the Purkinje fibers and see what's happening. This is kind of difficult to do. So here's a picture of a canine heart, a preparation that we developed where we opened the heart through the right ventricle, through the septum, laid it open. You can see here is the anterior lateral papillary muscle. Here's the posterior septal papillary muscle. This is the septum that we cut through, and you can see false tendons and things running down. This magenta maroon colored structure on the surface here is the Purkinje fiber network. So we used a solution, Lugol's solution, that's high in iodine. The iodine adheres to the glycogen in the Purkinje fiber system. But you can see this mesh network all along the endocardial surface of the Purkinje system. And so what we did is we took an array of electrodes. So this is a 500 channel array of electrodes, a 21 by 24 electrode grid. Placed it on the subendocardium, or on the endocardium, the base of this anterior lateral papillary muscle, and induced ventricular fibrillation is recorded. Now this heart is being perfused through coronary arteries. We put cannula in there and perfused it up until the point that we started ventricular fibrillation. But then we induced VF electrically and recorded. And what we could record there is, this is an activation from a single channel during ventricular fibrillation. And these large deflections are the electrical activations of the myocardium. There are also some little deflections that you can hardly see in this trace. If you take the first temporal derivative of that, you can see these sharp, narrow deflections shown with the yellow arrows that are the Purkinje activations. And they're uncoupled from the myocardial activations in this case, but you can see them throughout the course of ventricular fibrillation. So what we did was put this electrode array on and then mapped the endocardial surface of the heart. And what we found is that during ventricular fibrillation, the interaction between the myocardium and the Purkinje system was important, that activations tended to go both directions from the Purkinje system into the working myocardium, and the working myocardium into the Purkinje system. This kind of Minecraft-looking activation map, kind of crude resolution, shows red is the working myocardial activation that's proceeding. Yellow is a Purkinje activation. And in this case, we see a ventricular activation, myocardial activation that goes into the Purkinje fiber system. So, and this happened to me the other day. All right, well, we're going to say that wasn't playing. I just tested it half an hour ago and it worked. So what happens is an activation proceeds down this region, gets to a certain point, and then gets into the Purkinje system and explodes in the Purkinje system outward. So there's retrograde activation that occurs from the working myocardium into the Purkinje system. We also recorded instances of activations in the Purkinje system that then went into the myocardium. And that video is not working, and this one shows a focal activation. So activation that begins just within the Purkinje system and then spreads into the working myocardial cells. And this is important because it showed a dynamic interaction between the conductions. Oh, now that one's playing. All right. Interaction between the Purkinje system and the working myocardium. Yeah, you needed to have not the laser pointer, but just to make it work. Try it one more time. Okay, here we go. So this is the ventricular activation in red coming down. It gets to a certain point. There's a Purkinje myocardial junction, and then that yellow is the activation of the Purkinje system from there. In this case, the pointer was messing me up. Yellow is the Purkinje system, gets into the working myocardium, and then spreads through the working myocardium. And then in this case, there's no activation on the array, and all of a sudden it shows up in the Purkinje system as a focal activation, spreads, and then gets into the working myocardium. And so this was an interesting finding, that it isn't just passively being activated by the arrhythmia, but driving and integral to the rapid activation rate we see on the endocardium. So we thought, what happens if you take out the Purkinje system? What happens to ventricular fibrillation? So we did another series of studies with the same preparation, with an array in the same place, and some plunge needles along the side of the array. And the big difference here is that half the animals we treated the surface with a chemical that killed a couple hundred microns of the subendocardial surface, and presumably the Purkinje system, but left the myocardium intact, and then induced ventricular fibrillation. And what we found is that VF eventually stops, right? Insensitive clinicians have said, yeah, all patients stabilize, all bleeding stops, and all patients stabilize, even if it's at room temperature, right? VF eventually stops if perfusion stops. And what we found is that in these isolated perfused wedge preparations, that the VF stopped in half the time if we got rid of the Purkinje system, which is endocardial ablation. And also this activation rate gradient. So here the blue is our control hearts, the red are Lugol's ablated, chemically ablated endocardial preparations. And this rate gradient never develops if that subendocardium is wiped out, whereas this gradient develops in the control hearts. So if we eliminate this rate gradient, we cut VF off sooner if you get rid of the endocardium. Obviously not a clinical treatment. You don't want to eliminate people's conduction system to stop arrhythmias, but just trying to get at the mechanism of what's driving what. So we thought, all right, this is interesting. How does this scale up when we go from this isolated, perfused, ablated heart that's cut open to more intact in vivo kind of recordings? And so we did a series of experiments with endocardial baskets in the left ventricle. So this is a 64-channel catheter that's deployed. It expands into the left ventricle, makes contact with the walls, and then there's 8 splines with 8 electrodes on each spline. And we implanted an electrode in the right ventricle to induce ventricular fibrillation. And then we recorded ventricular fibrillation. And the 64 electrodes, here's the raw voltage electrograms. Here's the derived activation sequence of those electrograms. And in early ventricular fibrillation, it's this really chaotic series of activations that don't have a lot of pattern to them. Later in ventricular fibrillation, we found on the endocardial surface a much more regular synchronous activation that was occurring, even though the body surface EKG looks like DF in both cases. And when we did further analysis, we found, all right, there were 3 distinct patterns of organization of activity that occurred. This chaotic pattern that was both irregular in cycle length and activation, and also activation was present throughout the entire endocardium, so it was non-synchronous activation. We found this regular pattern that emerged where the cycle lengths of the activation were very consistent, but the activation again was present everywhere on the endocardium at some point. And we found a synchronous pattern of activation where there were rapid activations that spread through the endocardium, and then periods of quiet, no activation, and an irregular cycle length. And this tended to be related somewhat with time, as ischemia set in and the VF changed over time. In the first minute or 2 of VF, this chaotic pattern seemed to be the dominant pattern of activation. And then this regular pattern emerged. And finally, this synchronous pattern began to develop at 5 minutes plus. And you might ask, why does this matter? Treatment for ventricular fibrillation with an ICD that detects and delivers a shock in 15 seconds or 10 seconds might be quite different than external defibrillation where it takes 10 minutes to get a defibrillator there and shock somebody. So the mechanisms of what's driving VF might be quite different depending on the timing of VF. So we decided to look into this a little bit. You know, if you shock after a short period of time, you shock after a longer period of time. And in this set of studies, we did short duration being, 15, 20 seconds of VF start to deliver shocks versus after 3 minutes of ventricular fibrillation starting to give shocks. And again, we put a basket in, we put ICD coils, so there's a shocking coil in the right ventricle and another one up in the superior vena cava, like an ICD would have. And we induced ventricular fibrillation and then started giving shocks. So in half a dozen animals, we started giving shocks within 15, 20 seconds of ventricular fibrillation induction. And most of the time, the pattern was this chaotic pattern in early ventricular fibrillation. After some time had gone by and some shocks had been delivered, we got a little bit of this regular and synchronized pattern emerging, but primarily it was this chaotic pattern. If we waited 3 minutes to start giving shocks, and we gave incrementally, we started at low energy, 2 joule shocks, and then went up until cardioversion occurred, until the animal was defibrillated. So we started at 2 joules, 5 joules, 10 joules, up to 50. And in long duration VF, after 3 minutes, we had animals that were in different types of activation. So we had some that were in this green chaotic pattern, some that were in this regular pattern, and a couple that were in this synchronous pattern. But as we gave unsuccessful shocks, lower energy shocks, before we had successful cardioversion, we always had conversion to this synchronous pattern of activation, and then we had success after that. And so what we think was happening in this chaotic pattern is probably this wandering wavelet reentry with lots of competing wave fronts. The regular pattern is more analogous to a mother rotor, a big driving circuit. And the synchronous pattern seems to be driven by activation in the Purkinje system. And with these shocks in long duration VF, we can eliminate the reentrant activations in the working myocardium, but still have ventricular fibrillation driven by the Purkinje system that needs to be terminated at higher energies. We also found in some other studies that the first activations following shocks, whether they're successful shocks or failed shocks, in long duration VF, were always preceded by a Purkinje activation. So you get activation in the Purkinje system is driving what happens after shocks, even if they fail. Again, this leads to our thought that the conduction system is what's causing shocks to fail and leads to recurrence of ventricular fibrillation. So we did a number of other studies to further investigate what's happening with the His bundle, drop from the Purkinje system. In an isolated rabbit heart prep, we placed a grid of electrodes that were closely spaced over the His bundle, and part of the array would be on atrial cells and part would be on ventricular cells. And we did some tricks with Laplacian, subtracting neighboring electrodes to find the local activation rate of the different types of tissue, ventricular, His, and atrial tissue. And we were able to separate out, again, the His activations from the working myocardial activations. And we found that in early VF, the underlying myocardium is activating more rapidly than the His bundle. But after about 2 or 3 minutes, the His bundle is activating faster than the working myocardium, which says, all right, maybe the conduction system, again, in prolonged VF is driving what's happening. We thought, all right, so if we want to intervene, how can we drive activation from in the His-Purkinje system and terminate those wave fronts if it's being driven, if the working myocardium is still feeding some wave fronts back. And so we decided to do microelectrode impalements, floating microelectrodes of the His bundle and the local working myocardium. And what we did is we found the His bundle, put a microelectrode in the His bundle, put a microelectrode in the adjacent working myocardium, and then paced at faster and faster rates. And we found that the working myocardium action potential duration was always longer than the His bundle action potential duration, indicating that there might be an excitable gap in the His bundle relative to the working myocardium. So if we could pace faster in the His bundle, we might have a chance of capturing the His-Purkinje system, even at fast rates like ventricular fibrillation. So we pursued this in our lab, and Ankur Shah was a PhD student in our lab that did a lot of this work, devised this system that take up to 96 channels of signal, process them in real time, deliver pacing pulses, and tried to record from a high density array over the His bundle, and then deliver activation or pacing pulses during ventricular fibrillation. And what we found is that if we delivered pacing pulses, we could slow the activation rate significantly, statistically significantly, but we couldn't get anywhere near terminating DF. It was just too complicated. We couldn't get anything to happen. And so we paced both the working myocardium and the His bundle, and we found that pacing the working, somewhere in the working myocardium and the right ventricle actually changed the pacing cycle length. This is percent change in activation rate more than the His bundle. So we had a greater influence by pacing somewhere in the working myocardium than we did the His bundle. So a lot of work went into this, and it kind of catastrophically failed. It didn't do any good to try to pace the His-Purkinje system during DF. It just seemed to be too complicated. So we had to kind of go back to the drawing board and think about, what could we do to intervene here? So back to the conduction system. In cardiac electrophysiology, for decades, right ventricular apical pacing has been the norm. And then in recent years, there's been more interest in pacing the conduction system directly. So the His bundle and the left bundle branch directly, and for a number of reasons. The right ventricular pacing can lead to ventricular desynchrony and lower ejection fractions and development of heart failure. So patients that are pacemaker dependent and have right ventricular leads can develop complications of heart failure just from this. Biventricular cardiac resynchronization therapy has been developed and has been used for patients, particularly with long QRSs in some patients. However, a third of patients are non-responders to CRT pacing. There's also dysynchrony, and it doesn't follow the same activation pattern that it would if it goes through the conduction system. And these leads can be difficult to implant due to vasculature and anatomy. So conduction system pacing has increased. More interest in both His bundle pacing and left bundle branch pacing. And early trials have shown that patients with His bundle pacing have a lower incidence of both death and heart failure hospitalization than patients with right ventricular pacing. This is kind of an evolving, ongoing change to cardiac electrophysiology. So we thought, all right, our anti-tachycardia pacing, or our pacing of the Purkinje system in VF doesn't work. What about anti-tachycardia pacing? So anti-tachycardia pacing, ventricular tachycardia is somewhat simpler arrhythmia, right? So this is a rapid activation rate in the ventricles, can either be a reentrant circuit around an obstacle. Oftentimes this is a post-MI, post-myocardial infarction, where there's a scar and a wavefront can rotate around a single point, or it can be triggered by abnormal automaticity in border zone in areas close to the infarct and can emerge from so again, this can happen in myocardial ischemia, or it can be a focal activation ventricular tachycardia. But we had a speaker last month that said, all right, all these cases of sudden cardiac death aren't all cardiac. There are still hundreds of thousands of patients that die from sudden cardiac death each year. And what can we do about this? You either have to break these wave fronts or stop the triggers. And ways that can happen are through certain medications, drugs that either slow the conduction or stop the reentry, or inhibit these triggered activities. A lot of antiarrhythmic medications are actually pro-rhythmic, paradoxically. And the other thing we can do is defibrillate, shock people. And that has problems as well. I'll talk about that a little bit more. But to do some testing, we thought, all right, we want to interface the Purkinje system and see if delivering pacing pulses to the conduction system might be more effective than to the right ventricle. They currently do this in patients with ICDs. So we had to develop a model of ventricular tachycardia to test this in. So we developed a model of ischemia reperfusion injury in canines, where we could come back 4 to 7 days after an infarct, have a dog in sinus rhythm, deliver some programmed stimulation, induce ventricular tachycardia, and then deliver therapy. So this would be relevant for patients with implantable cardioverter defibrillators. Again, 300,000 or more cases a year of sudden cardiac death. There's approximately 1 million patients in the US that have an ICD currently. So these tachyarrhythmias can be terminated either with a big defibrillation shock or anti-tachycardia pacing. And so anti-tachycardia pacing is giving a series of pulses at just shorter than the VT cycle length that interrupt this circuit. And that's one way that these can be treated. The other is these large shocks. The problems with ATP in particular is that it's not always effective. It can lead to acceleration of VT, which is worse, or convert it to ventricular fibrillation, which is even worse than the VT. And large energy shocks are both damaging to the heart, and patients don't like them. If they're still conscious when they get one of these shocks that are less than a joule are described as extremely painful. So a 35 joule shock is been described as being kicked in the chest by a horse. So big shocks, while they terminate VT, are not great. So anti-tachycardia pacing, here's some traces from one of our studies. We have a sustained ventricular tachycardia here. We deliver a series of pulses at just faster than the cycle length, and you get conversion back to sinus rhythm afterwards. So this would be a successful anti-tachycardia train. They can fail where you have VT, deliver pulses, and the VT continues uninterrupted. And kind of the bad case scenario is, all right, you have you deliver anti-tachycardia pacing and you accelerate the VT, or it degenerates into VF. So those are kind of the three main outcomes. And I've mentioned this before. So large shocks are effective at terminating VT, but anxiety and quality of life are issues, as well as damage around the shocking coils. So if we can do anti-tachycardia pacing instead of shocking, that's much better. Now, just anti-tachycardia pacing, if you've got a reentrant circuit that's circulating around an obstacle, there's an excitable gap where you can stimulate tissue. And if you can stimulate this excitable gap tissue, you can block this wavefront and stop the VT from happening. So when you deliver an anti-tachycardia pulse, a lot of the times you're going to hit this wavefront, which is refractory, means you can't stimulate it, and it's not going to affect the wavefront. So you keep delivering pulses, and hopefully, eventually, your pulse lines up with the gap here, and then you interrupt the circuit, and it stops the circuit that's going around. So in right ventricular anti-tachycardia pacing, which is what's done in devices now, again, they rely on that one location to deliver the anti-tachycardia pacing pulse. Our hypothesis testing that we wanted to test was, all right, if we deliver this to the His bundle, left bundle branch, and it goes through the conduction system, now there's wavefronts coming through multiple different pathways. Maybe we can interrupt that circuit easier than we could from a single site. And so, we did a series of studies with a dog model, tied off the LAD, the thoracotomy, brought the animal back. We implanted leads into the His bundle, the right ventricular apex, and induced ventricular tachycardia. We did eight pulses, and we repeated that up to 3 times at both the right ventricular apex and the His bundle. And we had these 3 outcomes: successful, acceleration, or termination. And then we mapped the outside of the heart to see what was happening. And what we found in this first study was that we didn't have a significant increase in success rate in His bundle anti-tachycardia pacing compared to the right ventricular anti-tachycardia pacing. What was different was our adverse outcomes. Our adverse outcomes were about 3 times as high with right ventricular pacing than they were with His bundle pacing. Now, this study that we did, there were a lot of caveats to it. This was an open chest model because we put a sock on the heart. The device that we used, we put the leads in, but then we had it to an external device. We had to read the activation rate and then manually program in the pacing cycle length. And we thought, no, let's repeat this in a more clinically relevant setting. And so, the findings of that first study were that ATP wasn't better in the His bundle as far as effectiveness, but it was safer. So in our follow-up study, we did closed chest, transvenous implantation of leads. We implanted 2 ICDs, one to the right ventricle lead and one to the left bundle branch. We used the ICDs to detect the activation rate, cycle length, and to deliver the therapy. And so, here's our lead placement in the right ventricular apex, and one grows through the septum into the left bundle branch. And what we found here, essentially using the same protocol, is that we did have a significant difference in efficacy, where the left bundle branch lead had a 73% success rate as opposed to the right ventricular lead at a 54% success rate. And we also had increased safety. Again, about 3 times as many adverse events with the right ventricular lead than the left ventricular lead. And this, we're we presented this at a conference. We're working on working up this data. This we haven't published yet, but is really an important finding. If we can increase the success of anti-tachycardia pacing by using conduction system leads, could be a significant improvement in clinical treatment. So, things we're working on improving the leads for interfacing the left bundle branch and the his bundle. We want to do testing in other models of VT. We've got our one ischemia reperfusion model that we've done our testing in, but we want to see if this is applicable in other cases of VT. And we also believe that using adaptive ATP methods, where we either truncate or expand the number of pulses and change things, will give us higher success rates. So that's what we're planning on doing in the future. And we have to renew this grant next year, so we're brainstorming and thinking of ideas of what we can do to make that better. I've talked about this as we. A lot of people have contributed to these studies, and just within my lab, there's a whole crew that have worked on these studies. Dr. Ranjan's lab has been an integral part of many of these studies as well. Bob Hitchcock's a co-investigator that's working on the lead development with us as well. And a number of these studies were done at University of Alabama, Birmingham, before I came here. And our work's been primarily funded through NIH support. With that, I'll take any questions.
Did this work? Yeah.
Let's use one of the ones on the table. And
Oh, I see. I'll kick things off, and then I'll work out how to turn on the lights. Here we go. The defibrillators, the ICDs, really hurt arrhythmia research because many of us were focused on mechanisms of arrhythmogenesis. As you mentioned, yourself a big part of it, and sort of Purkinje fiber contribution to ventricular arrhythmogenesis was sort of emerging, and that work certainly has stood the test of time. But in the meantime, clinicians decided, well, that's all sort of fancy academic stuff, but I can put in a defibrillator, give a shot, and we're done. And after a couple of decades of throwing in defibrillators, you mentioned the burden of being shocked, which is non-trivial. There's also an enormous morbidity and even mortality risk from defibrillators, not just with implantation, but with infection, failed delivery, and also there's just astronomical costs associated. And so as a result, guidelines are being changed where clinicians have to be much more judicious about putting in defibrillators. So let's go back to arrhythmia research, right? How hard will it be to, in a practical way, to put in a sort of conduction system lead? In other words, I'm just making the assumption that this is where this work is going, where you can say, we don't have to shock the heck out of patients when they have a ventricular arrhythmia, but we might be able to pace them out, but we need a conduction system lead.
Yeah.
Is that something that's feasible, or it only works in an animal with incredible expertise and enormous amounts of time?
Yeah, I mean, this has been a topic at the Heart Rhythm Society meeting the last 5 years. It's been huge. His bundle leads and left bundle branch leads. So his bundle lead implantation, I meant to address your first part. ICDs, companies are also de-incentivized to do anything different. They make a lot of money with these devices. And so even biventricular pacing, they say, that works. We can charge a lot of money to put these devices, and we don't want physiological pacing because why put in a simpler device when we can sell the Cadillac version and make a lot more money? So companies don't like improvements to ICD implantation. So there is an investment from industry. But back to your question, there has been a lot of interest in, about 5 years ago, it was His bundle pacing. That turned out to be technically quite challenging. There are certain centers that did quite a bit of that, but it didn't take off in as a general practice kind of a thing. Higher thresholds was an issue, and difficulty of implantation. They estimate it took 20 to 50 cases before a clinician became proficient in putting these leads in. Left bundle branch pacing is much easier to learn. It's a bigger target area. You have to burrow through the septum to get to it, but people are more excited now, than 5 years ago. Nowadays, people are talking about left bundle branch pacing as the future. So that's, I'd say it's still not the primary thing that people do, but it's probably, I don't know if Ishi can help me, 5 to 10% of cases might get a conduction system lead nowadays, or some percentage of patients. And
20%.
20%, about 20% relation.
okay, so it's up to 20.
We keep 20 our 20. Really difficult to find his bundle branch basically.
His or left bundle branch, either one.
Very good.
Okay, so 20% is not insignificant number of leads that are going in. So it's definitely on the rise. I mean, 5 years ago, it would have been 2% or 5%, right?
Yeah.
It's definitely increasing. So his conduction system leads are coming. No testing has been done on anti-tachycardia delivered to conduction system leads. I mean, there's nothing published on it other than our one paper that we've got out and the one we're working on. There are no clinical studies. So we think this is an area that's important to investigate. What's happening? What happens if we start putting these leads in?
And then just a follow-up question to that. It's very interesting. By the way, I know a lot of times, well, more than one fellow has accidentally crossed the septum from the RV to the LV. Now you can just say, wow, it's shooting from the left bundle branch. You got a crystal ball, all right? And I'll give you 3 directions. And this is speaking to all the folks that are sort of the early stages of their research careers right now. And one direction in terms of addressing ventricular arrhythmogenesis is to improve the approach and bring anti-tachycardia pacing, based on lead placement, make it, much more viable than currently is. And it seems like that's actually a trajectory that's only gains steam, right? The second approach to a sick ventricle, or at least an arrhythmogenic ventricle, is to use a gene therapy or pharmaceutical therapy just doesn't work. We can accept that, but to use basically a molecular technique to repair the heart, which is going on in many places, right? And
Sure.
the thrust of a lot of basic work that's looking to be translated. And then the third option is just fix those hearts, and the electrical system will be fixed with them. I normally wouldn't say that, but I'm just referencing some of the other work that you do. Where's this all going? Just give some predictions and some advice.
So obviously, anti-tachycardia pacing is entirely reactive. It's responding to a problem, but it doesn't do anything to fix the substrate, right? So it's a treatment, not a cure by any means. ICDs have been shown to stop VF and bring people back from unrecoverable arrhythmias without an ICD. But it's kind of circling the drain. You're already sick. You've got a problem. You're not fixing the problem. So something that curative would be much better. Gene therapy that addresses the substrate that fixes what causes the arrhythmia would be the way to go. It's still early. I mean, there are things that have promise, but we haven't gotten there yet with what that is. Again, the antiarrhythmic drugs are pro-arrhythmic, and you can cut down on incidence of PVCs and arrhythmias and still have mortality go up. The MADE-2 trials shows that inappropriate shocks increase mortality too. And the number of shocks increases mortality. So this is kind of a temporary fix, but it's not the cure. So I do think we absolutely need to understand the mechanisms, and how to fix things on a molecular cellular level is the long-term way to go, for sure.
Great. Any questions from Joe? Can you just hit a speaker? Yeah.
Can you hear me? Oh, can you hear me? Okay. So one thing that's that's kind of come to favor now clinically for refractory ventricular fibrillation is to administer 2 shocks from 2 different vectors. They call it dual sequential or double sequential defibrillation. Mm-hmm. I'm curious, when you've done or studied ventricular fibrillation and studied resolution after having a shock, after having single shocks, if you've noticed parts of the heart where, like small areas where fibrillation is continuing to occur, after one shock that then restarts the fibrillation.
Yeah. I mean, I did that kind of work for my PhD and initial postdoc work with multi-vector shock stuff. There's the critical mass theory of defibrillation, that what you have to do is you have to terminate these reentrant wave fronts in a critical mass of the heart, somewhere between 75 and 90% of the tissue. And what happens with a typical ICD lead is you have very high current density immediately surrounding your electrodes. So you've got damaging current densities around your electrode, and then you've got the stuff that's further away from your electrode that doesn't get captured. And to capture that, you have to crank up the amplitude even higher around your electrodes. So by spreading the electrodes out, what you can do is you can lower the amplitude, because you have to capture an area around this electrode and an area around this electrode and get their overlap to kind of come together, rather than all from one electrode to capture the whole heart. So you get incremental improvement with additional electrodes. You can reduce, there are papers that talk about it, a third or even a half of the energy total by splitting the current between multiple electrodes. But it's never going to be, if you're at a 35 joule shock, you might be able to go down to 20. It's never going to be like where it doesn't hurt. You're not going to be able to drop to below 1 joule or non-damaging. So again, it's an incremental improvement, but not revolutionary, my opinion.
I think we're just about at the hour. Actually, we're just
1 o'clock.
We're just over the hour. Yeah.